Good morning.
Oh, I was like, okay, don't tell me you can't hear me. I had a whole face. Like, are you kidding me? We just did this. We just tested this. Good morning. Good morning. Okay, let me get rid of that. Okay, we're good. We're good. Well, good morning, everybody. How's your week?
It was good.
Oh,
It went by fast,
it did.
in my opinion.
It did. It was, I looked up like, oh, I was supposed to do this, that, and the other. And okay. Like, okay. Yeah. Monday was a Monday though. I mean, stuff was just coming in, and I'm like, oh, Monday was a Monday though. I will say that. But then it got easier. And then I think I forgot like what day. I thought it was I was a day early. No. You know what? My Fitbit for some reason. So I wear Fitbit. There's no compensation from Fitbit on none I'm about to say. But it's a day early. I do not know how my Fitbit, it says Sunday right now. So I've been looking, so I was looking at dates and I happened to look down like, oh shoot, wait, I know it's something I'm supposed to do today. And then not realizing, oh, this is a day early. So I think that's what has me confused with this particular week. And I've tried to get it to sync up and do, and I don't know. I'm about to throw it. I didn't want to do it. I think I'm about to get the Apple Watch. Because I've been holding on to Fitbit. I love my Fitbits. I've had them for years. I've had different bands and all of the things. I was all caught up. But this right here, I can't have this. I can't be confused.
Can't be a day.
No. I guess it could be worse. I could be a day late. So I guess it could be worse, but okay. Well, welcome everybody to our Saturday morning tea, where we discuss health information, news, education, certification tips, entrepreneurship, compliance, medical coding, the AMA, and all the foolishness that they bring, and the great things they bring too. But but their foolishness, boy, when I tell you they are on it this season. Really the revenue cycle at large. And as you come in, don't forget to hit the thumbs up or like button. I'm Clarice Warner. I'm the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. And PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance and education. Now, before we get started, let me ask you, do you personally, know what it takes to be a certified marketable medical coder? Well, before I introduce my co-host, let me share with you information on a free, yes, free email course on the 5 steps to become a certified marketable medical coder.
Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder.
Ow, get it. Okay. Told you I get caught up every time. If you are joining us via Clubhouse, feel free to click the link at the top of the page if you are interested in getting more information about the 5 steps to become a certified marketable medical coder. Let me just say, you see how I just introduced all of that Clubhouse lingo? Look, I'm learning. I'm trying. If you are joining us via YouTube, Facebook, and LinkedIn, you can check out the video description for the link. I promise you it's in there. I know it's a lot of information, but that link is there as well. So joining me today, there's no mystery. There's no sliding in. Joining me today is my co-host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. Before I start my introduction, the reason I've been up since 7 a.m. I'm not going to oversleep, and I had 2 alarms set. Oh, it's light outside. What time is it? But hello, everybody. My name is Jesse. I live in Philadelphia, Pennsylvania. I have been an LPN for 3 decades. During the pandemic, I transitioned into HIM in 2014. And Reese said she can't hear.
Okay. Try now.
So in 2014, I transitioned into HIM. And during the pandemic in 2020, I created my own company called the Coding Nurse LLC, where I help nurses and other people in healthcare with clinical backgrounds transition into the wonderful world of HIM.
And how's that going?
It's going great. Actually, on Monday, I start an ICD-10 PCS course.
Oh, look at you. Woo, you breaking down the breakdown. PCS, come on now. Come through with the PCS. Now, y'all know I'm a professional coder, so I deal on CPT. However, I took a PCS class a long time ago and learned and got, I think I still got my flashcards and all kinds of stuff to learn and understand PCS. So if you get that PCS down, inpatient coding is for you.
Can I tell you, I love PCS. I can't stand PCS.
And I am just opposite. Even though I love ICD 10CM, that's the beauty.
Right.
It's that like you just got to think a little different. And I think I've been thinking so the way of CPT world so much that it's like, okay, you gotta really think different in the PCS world. So congratulations.
And what a lot of people don't understand is you really have to pick a side.
You do.
It's almost impossible to do both.
You do. And that's why, I'm nervous because, there are several organizations that are trying to have their coders be dual and have both foots on both sides. Both feet. Did I say foots? Both feet on both. That's why confusing it is. Both feet on both sides. And it's like, I don't know.
There's too many twists and turns and subtleties in both code sets.
Yes. And that could be a little messy. So.
And the thing is, it'd be something different if they paid them accordingly. But they don't.
Sir, let's call a thing a thing. Let's call a thing a thing. Oh my God. Okay. Oh, look, we didn't already started. That was a church announcement all day. Okay, but before we jump in any further, let me remind you that you can join in and add to the conversation. We look forward to you jumping in and adding to the conversation. If you are on Clubhouse, come on up to the stage. Just raise your hand. We'll bring you on up. Don't be shy. Your opinion matters. And of course, it's welcomed here. Also for Facebook, YouTube, and LinkedIn friends, you know what to do. Use the chat. The chat be chatting. If you have a question in the chat, though, the only thing I ask is please place a Q first so we know that it is an actual question and we don't miss it. So for those who are joining us or watching the replay today, we are spilling the tea on compliance. Yes. One of my favorite passions. But yes, we are doing that. So before we, I was waiting. Look, I've been looking to see also before we spill the tea on compliance, let's get into our church announcements. Wait a minute. Just so you know, yours is on the way. When I say I wasn't playing, I wasn't playing. Woo. Yes. Okay. Our church announcements. Okay, so today's church announcement actually is really hot off the press, and I just saw this today. So we've talked about Medicare Advantage and the Medicare Advantage plans and how they've been getting a lot of scrutiny recently. They've faced allegations of billing fraud from the federal government and are being probed by lawmakers over high denial rates. Well, in the Becker's Hospital Review, Jacob Emerson put together an article that talks about, what hospitals are now doing to fight back. And one of the things they're fighting back with is they're just not accepting any Medicare Advantage plans. There is a huge list of hospitals. So if you have some seniors who are on Medicare and they're on Medicare Advantage plans and these systems are all over the country, make sure you reach out and find out whether or not the facilities that they're going to are accepting them. Some of them are selective. Others are like, we're not taking any of them. and this is nothing that is new. I mean, people have been doing this for years, but they are noticing that it's at a higher rate, and a lot of them are doing it because of the increased scrutiny that has come from the government on these Medicare Advantage plans. So Mayo Clinic warned Medicare eligible patients in Florida and Arizona in October that it will not accept most Medicare Advantage plans. Vanderbilt University Medical Center in Nashville, Tennessee, planning to drop Medicare Advantage plans before reaching their contract agreements in March. Cameron, I think that's in Missouri, Regional Medical Center. They're not accepting Cigna plans in well, they've stopped already with Cigna Medicare Advantage plans in 2023 and plans to drop Aetna and Humana in 2024. Let's see. Stillwater Medical Center in Oklahoma ended all in-network contracts with Medicare Advantage plans. And another thing they're saying, it's the denial rate too. There's a huge denial rate. And so they're not getting their money. They're not getting paid for the services that they're providing. And it's not sustainable for these, and some of them are actually smaller bed hospitals, but it's not sustainable for them. And they're facing rising operating costs. So getting a huge denial rate is they can't do it. They can't do it anymore. Brookings Health System in South Dakota will no longer be in network with any Medicare Advantage plans in 2024. Bend, Oregon-based St. Charles Health System has taken it a step further and is not only considering dropping all Medicare Advantage plans, but it is also encouraging its senior patients not to enroll in the private Medicare plans during the next open enrollment period. So if you want to get some services over there, they're directing you away from Medicare Advantage and having you stay with traditional Medicare. Yeah. Again, they're citing the higher rates of denials, longer hospital stays, and the overall administrative burden for clinicians. So yeah, that is the church announcement. Go ahead.
I just want to. I just don't understand these providers are so burdened with proper documentation. Like that is your job. Like seriously, like that's just like a teacher. Oh, I'm so burdened down by having to teach in a class all day. That's what you do. I just don't get it. Like, and I came from a Medicare Advantage background. It is not hard. Now, if the crux of the article had been it's not profitable because the reimbursement is not what it should be, I get that. Because these people are sick. And this is why they are around here doing all this fraudulent coding and all this upcoding, trying to maximize money because these people eat up some money.
Here go the tea, y'all. Here go the tea, Lord. Okay, go ahead.
So I just don't understand. And then what they're trying to do. The reason why people have a problem now is because the free COVID money didn't dry up.
Uh-oh.
So now they're back to the old hustle. So the new hustle is over.
Ooh, and with that new hustle being over, that hustle comes with some repercussions that are following, which is another church announcement. These post COVID-19 payment, the reviews are flying left and right, flying.
Well, we talk about so much stuff, but during COVID, I met a nurse practitioner because they were doing COVID testing up the wazoo. They were testing everybody. Didn't have any kind of documentation, no ID. They was just testing people and building the government. She had already, at the time I met her, she had already gotten over $900,000 in testing fees from COVID. And I asked us, do you have any proof or do you have any documentation of the people that you saw? Well, no, they said you didn't have to. I said, they who?
Was this the one that was with HRSA, doing something with HRSA?
Oh, they were all doing something with HRSA.
Okay. I mean, but they were going by something that they read or hadn't read, or something that if you read further, they gave you information on what it was that you needed to do. So, yeah. Okay.
And because what I couldn't understand is, like, come on, y'all, like, nobody can walk into a doctor's office without any ID and be seen. Let's just stop it.
Ooh, chill.
That ain't my cross to bear.
No, we're gonna have to place all of these folks on the altar real soon. Send up some
the altar in a payment plan.
Yes. Wow. Ooh, yeah. So it's coming. And the one you sent me the other day about the E&M, oh my God, that I've been waiting for, because there's actually going to be some new E&M changes coming with 2020 with 2024 COSAP. Yes, sir. There's some more. But I've been waiting to see what the fallout of the new E&M code changes are, and what that looks like from a government perspective. I know, like, some of the things that we've seen, and most people that I know that have done who had to make the shift with the new E&M codes for auditing. It's like, well, it seems there's a little less scrutiny. So it seems like, okay, well, we got our marching orders. We got it needs to meet this, it needs to meet this, it needs to meet that. But there's even more gray in some of those areas. And some of the gray involves the specialty that occurs. So, and it's not specialty specific. So, and because of that, I think some folks who probably don't necessarily need to get the grace is getting the grace, which I think, and I may be wrong, may end up hurting them on the back end when it comes to the government's reviews of these cases. But we'll see. We'll see what it looks like. We see. Good morning, Vicky. Good morning. Good morning, Renita. Okay, I guess we can hear you. I guess everything is everything, sir. I haven't heard anything else. All right. So let's get into our discussion today. So we started talking about compliance a little bit from the infographic that I received, or that I found or ran into on LinkedIn from one of the compliance. He's been like a compliance staple in the healthcare compliance association, and I believe he's an attorney, Frank Sheeter. But he gives, when I tell you, he gives the most comprehensive update about compliance findings and hot topics and trends. And I think he has like an automatic slot in the HCCA Compliance Institute. So that's their annual meeting. And that room is packed. When I tell you that room is packed, everybody got everybody like, okay, what we got to do. So he's really, really concise, and brings the information about what we need to look for. Between him and the federal government coming in and providing their perspective, those are probably two of my breakout sessions, or that I always go to. I always will attend those, even when they allow us to do it virtually. But I wanted to show you the infographic. Let me see. Yeah, okay. Want to show you the infographic here of the roles of the compliance professional. And he did a little wordplay and wordsmithing, if you will. But one of the things, the roles of a compliance specialist is an analytic ace. And he says they diligently examine and interpret applicable standards. So yes, they meticulously conduct risk assessment and compliance reviews, and they use data-driven insights to implement effective strategies. They're also an empathetic enforcer, establishing strong relationships with stakeholders. And that, to me, is really key for compliance professionals. Emphasizes importance of compliance for the well-being of the organization, and encourages open communication and offers support during challenging times. Innovative investigator, embraces technology to streamline compliance processes, seeks out new resources to enhance compliance effectiveness, and uses data analytics to identify potential issues and opportunities. They are also collaborative coordinators, creates a team-oriented compliance culture within the organization, collaborates with various departments to ensure a unified approach to compliance, and facilitates training to empower employees to be compliance conscious. They are a strategic sentinel, develops long-term compliance plans aligned with organizations' objectives, monitor changes in regulations, and anticipates potential compliance risks, and acts as a strategic advisor to senior management on compliance matters. And last but not least, they are the communicative crusader, has communication skills to convey compliance policies and updates, advocates for compliance awareness throughout the organization, and builds trust with regulators, reflects commitment to compliance. And so this was from the Sheeter firm. It was an infographic that he put together. Now, Mr. Jesse, before you get started, because I hear you in my ear right now. Let's just say this. This is the ideal for compliance. This would be an ideal situation. I know firsthand of many compliance departments that I've worked with, I've partnered with, and just know the compliance officers as colleagues. Everybody don't get the same resources given to compliance, unfortunately. And compliance, for the compliance department to have the responsibility that they have, they are often, because they're not income generating, and keep it 100, let's keep it a buck. You know, income generating things get the money when it comes to these organizations. So because it's not income generating, folks don't necessarily see the value of having a robust compliance department. They hear you like, yeah, enforcement, this, that, and the other, monitor, train, but they don't want to put the money where they don't want to put the money there. So with that being said, there are plenty of one-person compliance plans. Now, we're going to talk a little bit more about what the government thinks about an effective compliance plan and compliance program. And for one person to be responsible, oh, I still got church announcements. I'm sorry. For one person to be responsible for that is crazy. Now, one thing that I can say that can help, even with a small compliance department, is you got to find advocates. You have to find other stakeholders that believe in compliance. You have to find other folks that are willing to share resources that they have to help with compliance. Specifically, for me, specifically in the revenue cycle arena, because we all know this is where the rubber meets the road as it relates to the business of healthcare. So one of the things that we did was to have a compliance committee. And so if you are a small team department in compliance, it's great to try to find allies specifically in revenue cycle. You need allies in other places too, particularly if you have identified areas of risk. So you need allies there too, but definitely in revenue cycle to help you understand and work through and even offload some of the monitoring efforts, because some of the things they may be already doing anyway. So instead of recreating the monitoring wheel, here's an opportunity to have a conversation. Hey, are y'all looking at this, then the third? I think we talked about the PEPR reports a while back. Are you looking at the PEPR reports? And maybe they don't. And so sometimes, because the PEPR reports usually come up through your quality people, they don't necessarily let the revenue cycle folks know what they're seeing. And it kind of dies because they have what they need to get out of this particular report and what they were looking for. And it's like, okay, no, but that report has gems in it that can help compliance, quality, and revenue cycle understand what's happening within a particular organization. And by just taking a look at a few charts that may be outliers that have been identified by that PEPR report will assist in the monitoring effort across the organization. The last thing I say before I let you get in and hit us with the 1-2 is compliance is everybody's responsibility. And I say that all the time because folks think, oh, well, the compliance department will take care of it. No, the organization is responsible for compliance. And compliance actually starts at the top. Now, the compliance department and the compliance professionals are tasked with making sure folks are educated about what that compliance culture is, by all means, at the orientation, and should be providing annual compliance training and should just be having some regular pop-ins and conversations about compliance. But it's the organization as a whole that is responsible for the compliance culture there. Okay, Mr. Jesse, I'll step down.
Okay. So what I will say is that it doesn't, well, you and I have totally different compliance experience. And while compliance is not income generating, it's certainly income saving.
Amen. And that's why we feel like they need to be putting that money over there. But go ahead.
They really do. So, I just don't get it. And sidebar, what they need to teach doctors about the revenue cycle. And they need to teach doctors about these weights, these DRG weights, these
RVUs and all of the things.
Yeah. Because they don't understand how it works on the back end. They really don't. And they think that because they have a doctor, like for instance, like a lot of people think that, oh, when you hear sepsis, you think that sepsis is like it's going to pay you a lot of money. Sepsis does not pay a lot of money in terms of reimbursement. And very, very rarely I try not to sequence sepsis first. I try to find something else that was present on admission that was treated as well. And, you know, and I try to make that the primary diagnosis. Sometimes you just can't. It is what it is.
Mm-hmm.
But they don't understand. They think that because somebody has sepsis, they're supposed to have 17 days, you know, afforded them for this condition. No. No. Like, and actually, another sidebar. I had a lady who she has the second highest DRG weight on the chart. I was like, wow. And the geometric length of stay is 29 days.
Oh, wow.
I mean, she's really going through it. But anyway, get back to compliance though. Like, it's not, well, none of this stuff is hard. It's really not. But they make it so hard, and the problem is people don't want to listen. And people don't want to say the right thing to the right people. Everybody is trying to, you know, have a campfire and share s'mores. No, this is a business. They don't realize how many people are going to put eyes on this chart. Charts go all around the country for people to review and analyze and cut up. Yeah. And they don't understand it. You have to have your ducks in a row. You have to have your documentation. You have to have a standard that you follow. And I don't understand, like, I just don't understand how compliance has become the redheaded stepchild when it is so important.
It is. And
it is so important.
There are two organizations that I always give kudos to related to their compliance program. One is an academic medical center, and the thought was to partner with the medical school, and because they had a medical school there, and because we all know providers are not taught anything about the business of medicine. So they don't get a full overview of what any of that means. And then they're thrown out there like, go on out there, make your money. You're gonna get all this great money and this, that, and the third, and clueless. And this was prior to the employing of providers that has happened within the last decade, actually, where, well, they did it at it's ebb and flows, but so far this has been the longest run of this employing of physicians from health systems. And that's a sidebar. Like they got it off because of electronic medical records. They couldn't afford to do it on their own in private practices. And so one way that they got to get them over here was the carrot of providing them electronic medical records, which has now become a burden to them. We can go on and on. But anyway, so they had the forethought to say, you know what, we know that they don't get a specific course or time where they really have to dig in and understand the business of medicine, but at a bare minimum, the compliance department partnered with the GME office and decided that we're going to teach these residents a little bit about documentation at a bare minimum and how their documentation impacts the business of healthcare and what that looks like. And when you hear about the codes and you hear about this, so it was a high level overview, but it was enough. But the documentation piece was a deep dive, and let them know that we will also be reviewing on a regular basis your documentation. And these are the things we were looking for. So again, this was from old E&M guidance, but these are the things we would look for. And so we kind of gave them a documentation course. And they were so appreciative, even if, they came through the school, went to get their medical training, but went off wherever they went, because all of them didn't stay with us. but they were so appreciative of having this knowledge. And the comments we would always hear, everybody needs to have this. Everybody needs to know this. My friend who was a doctor going to so-and-so, they have no idea about this. I'm asking them questions. They looking at me, they confused. Everybody needs to know this. And so kudos to that organization, and prayerfully they're still doing that. The other organization that employs providers, even though they sometimes make their employed providers feel like they're different types of employees, and I will have to, bring everybody down. You an employee just like everybody else. You just have a different title, but you're still an employee and must follow these employee handbook rules. Anyway, but we had a separate session for all employed physicians, and it was a separate session where they needed to know and understand things that were relative to their duty, but it was a whole compliance piece. And while we didn't go deep into the coding aspect, it was primarily focused on fraud and abuse, what your documentation can keep you out of, what your documentation can help you with. We talked about just all of the high level government areas of risk with them. And CMS had put together, I want to say it was a compliance provider handbook of sorts. And we kind of just took the information from that. And actually, I put it together. So we took the information from that and provided additional stuff that was relative to the particular organization, just to let them know this is what's happening, this is what we're doing, because this organization also did routine monitoring of provider documentation, and they were appreciative of that as well. Like, oh, I've been practicing medicine for years and had no clue of what those people back there in my back office was doing. And it's like, yes, that's what they're doing. And that's why they keep tapping you on the shoulder. Sir, ma'am, could you take a look at this, that, and the third? Sir, ma'am, make sure, you do X, Y, and that's why you're having these conversations. Well, of course, now with the electronic medical record and people are all over the place, you don't have, and in these organizations, it's become production. You don't necessarily have that warm and fuzzy elbow to elbow rub with your providers to be like, now, what is this? Because I would do it all the time. What is this? But they still need to know, and they still need to have the conversation and reminders on a regular basis. Because, sometimes we forget things, but they need reminders too. So to me, those were the two organizations that kudos to them for having that type of structure. Go ahead, Mr. Chester.
You made a very, very, very key point. I really think that is one of the downsides of remote work, especially with this, because what is going on where I work now, it has come out that, to be honest, the physicians would like to have more of a relationship with the CDI. They don't know who they are. And when people are comfortable with you, they will ask you things. They'll run things by you. And if you don't know who this person is, then you're going to be a little reluctant. There's not going to be that open exchange. And I think that is really key, because I think, I don't want to be a provider. That's why I'm not one. But because they are pulled from all angles. Everybody wants something different. Case management is asking you for this. Quality is asking you about this to avoid a PSI. CDI is asking you for this. Coding is asking you for that. So they're being pulled from all kinds of directions. And I'm sure if they had a rapport with somebody and something they're not sure about, they could run it by them to get an explanation. I think that would go, leaps and bounds, towards bridging this gap.
I agree. And to that point, I believe that's why it's important that compliance and revenue cycle, CDI, all of these different areas are collaborative and all on the same page, because here's an opportunity. While they may not have enough compliance people to get to that provider, they do have certain relationships with CDI because they've received queries or received information or conversation, or they've even reached out to a person and that they may feel comfortable with, and prayerfully they're doing things in a compliant manner. But then they can share, the additional components of that and have those conversations. The one thing that I had that used to take me over the edge was we would get people, well, not necessarily take me over the edge, but you have to know your people. You have to know the people that are doing the job. And so we had people who, and it's a different skill set, and I appreciate that, but it's really great for folks to be honest about the skill sets that they have. Let's start there. Let's be honest about your skill set. Now, as a person who is doing compliance reviews or audits, that is usually a multi-step process. So you have somebody who's actually going in and reviewing the charts and providing the information. You have somebody who's doing kind of the additional analysis across the board of every individual provider, but then the group or practice or specialty or whatever as a whole, and ultimately comparing it to the organization as a whole. But you also have somebody who has to relay that information back to that provider. And I remember the first time I saw it, I was like, girl, if you don't say something, like she was just, she was so in awe of the provider. Like she put him on a pedestal. Dude just walked in the door and she was like, oh, Dr. Jones. And I was like, ma'am, we tell Dr. Jones he got a 0 on compliance accuracy. Ma'am, tell Dr. Jones. Yeah, right. Tell Dr. Jones. I mean, it was like, oh, and I was like, I couldn't believe it. You know the what is that? The little cat, the Puss in Boots cat with the eyes get real big, and you be like, oh,
yeah,
I swear, just like that. When dude walked through the door, and I was like, absolutely not. So, to the point afterwards, we had to pull her aside. Like, do you not feel comfortable having these conversations? Because sometimes they're crucial conversations. Sometimes it's like, okay, well, it's just a couple things here and there. Sometimes it'd be like, sir, ma'am, I don't know who taught you how to do this, but you need a redo all over because your documentation is trash. Trash. How have you been surviving? But yeah. No. Oh my God. You cannot. You got to have that thick. And you also have to be in a position and understand that, to your point, you got all kinds of folks coming for you and pulling for you and asking this and asking that. So you have to take, and each person is an individual. So you have to take all of those things into your knowledge of who that person is that you are about to approach. And we're human. It could have been a bad day today. It could have been a great day today. You got to take all of that. And so you gotta lightweight know people or watch people or listen to what they're trying to tell you, because they will eventually tell you what their needs are. And you have to find that sweet spot in order to tell them what you need to tell them, but also be helpful for them. And really, that's another skill, a soft skill that some compliance folks don't understand that they need to have. You got to come in like, you can't be a fangirl, but you got to come in being a help, a resource. And that was the one thing that I always prided myself on as a compliance professional. I am a resource for you. At the end of the day, good, bad, or ugly, I'm providing you with the information that you need to do your job. And that's provider, that's staff, that's senior C-suite, that's whom the board, this is my job, is to provide you with the information for you to take your next step. Now, hope preferably that next step is a compliant one, but if not, that's a choice you chose to make. My job is to give you the information, period. Go
I that was a perfect segue. I have to jump back to the church and because this is all tying in with compliance. Because now, because of the COVID money drying up and these Medicare Advantage programs, now there is a push for HCCs to be captured in the inpatient setting.
Okay.
It still comes down to has a condition been monitored, evaluated, assessed, or treated? Just because it's on a problem list doesn't mean that you can code it. It has to. Jesus. Okay. We know that on this problem list it says that Frank Myers has COPD, but was it monitored, assessed, evaluated, or treated during this inpatient stay? Even if you say stable or bronchodilators, something. You gotta give us something in order to. So now that's the big push. But it's always been a problem because even when I was doing it, there's a lot of information that's discovered in the inpatient setting that they consider incidental findings, but they don't necessarily treat it. So then what happens is how these people get into trouble with compliance and with this fraud stuff is they might see on an echo somebody it says that their aortic root is dilated. That goes to thoracic ectasia, which is an HCC. But what did you do? I mean, it's on an echo, which that's considered radiology. So you can't abstract it. Okay, the doctor, I've yet to see an inpatient doctor document thoracic ectasia. I don't know. So how do you want to capture it? And it's just like, that's the kind of thing that gets people in trouble.
So is it the HCC coders that are getting folks in trouble too? Or is it just the providers? Or and the EMR system that they allow to automatically just push stuff from the problem list? I mean, I think it's multiple. Okay.
Because what happened, my suggestion was when they go through, because everybody goes through, that's one of the measures for HEDIS. Everybody goes through a post discharge reconciliation. So why not have a nurse or why not have a coder go through the record and in a separate mechanism say these conditions were identified during the inpatient stay. This is what you need to evaluate. But the way that they do it is they have the coders suggest the codes to the provider, which you cannot do.
Correct.
That's how they get in trouble.
Yep. Wow.
But that's all part of compliance. Yeah. See, compliance should be involved in saying, well, this is how you get from point A to point B.
Exactly. They should involve in the process and helping them pull that together and understand. And I think if they have a broader understanding of the implications of what they're doing and why, then that will help in deciding how to move forward with the process. Interesting. So let me also share lastly, and this is, I think it should be in the description box for the folks joining us.
You know what? I'm thinking this might be a part 2 because this document is really, really deep.
Okay, so I should wait. So we'll part 2 that. Okay, we'll part 2 that. It'll still be there if you want to take a look at it and then have questions. So in March, the government came back and they've always had this manual, but they went and revised it and was very specific. Now, it's very specific, but then they kind of walk it back. So they'll take a step and be like, but this is not for everybody, and this is not the only thing, but you need da 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 da. But you don't really need to have so, but you really need, so you got to kind of read between the lines of the document. But this was a document that they put together. Oh, well, that's cool, because when we do the top part 2 of it, I can go through this document. And I also wanted to talk about what the government has put out. Well, this kind of listed too, of what elements are needed in a compliance program as well. So it kind of marries that, because some of them they talk about, some of them they don't. But when it comes time to mitigate for the fines that you hear or repayments that happen, one of the things that is a factor is whether or not that organization has a compliance plan. And the government has now added an additional layer to that to put together kind of a checklist to determine whether or not that compliance plan is effective. Because it's one thing to just have a compliance plan, and you hear this all the time, this just on the shelf, because you got a lot of people that do that. Oh, yeah, we got a compliance plan that lists all the policies and lists all, and they ain't been updated in years. Folks don't even know it exists. Folks don't even know those policies. Just a whole hot mess. However, the government, they're part of their job and their investigation and due diligence is to validate the effectiveness of that compliance plan. And so the document that we'll talk about next week kind of itemizes their perspective and what they're looking for with that. So I won't rush through it, because yeah, we are close to the top of the hour. So I'll give some grace, because Mr. Just said it's a very important document and you need to know. And it is a very important document, not only for compliance professionals, but then again, it helps understand, what needs to happen within the organization. And honestly, this document isn't just for healthcare organizations. It's for any organization that requires a compliance program. So very, very good find. Very, very good find. Okay.
Yeah, it was.
Yeah. So I was excited. I was going through it last night, like, yeah, look at this, look at this, look at this. We've been saying this. Yes, yes, yes. So I guess
it lays it out.
Lays it out. But I think the ultimate takeaway for us today, one, for those who are in decision-making power, who have decision-making powers, get the resources for your compliance department. Get the resources to add the bodies and pay them the money that this due. Let's start there. Second, for those who are in compliance, get to know the people in your organization. Get to know I know you know the senior leaders, because you have to have conversations with them. You, depending on what your role is, you may know your board of directors, because oftentimes the chief compliance person has a dotted line to the board. And the CEO in a good compliance plan. There's a whole other conversation about other folks that they should not have a dotted line to. And we can talk about that too. I think that might be I think I did see something about the governance structure. I think that's in that document too. Because the government did weigh in on who the compliance professional needs to report to. But the other thing is, get to know the people. You don't necessarily have to know the frontline people that treats the patient or provides the services for the patient, but you do need to know the director over that department, because that person or even a VP or director or even a manager, if you could, they can help you understand what's happening, especially in your risk areas. What's happening in that risk area? So you all can have a conversation. Hey, we know this. We've been getting information. The government is looking at this. Oftentimes, and most compliance officers will check out the OIG work plan. Okay, this is on the work plan. What's happening over here? We haven't got tapped, or we don't have a letter, but let's make sure our stuff is on point. That's how you stay ahead of this information. And again, depending on the strength and numbers of your compliance department, you may not have the resources to do that, but you have allies in other departments who can assist with that. Like I said, we had compliance committee. I had several members of revenue cycle. We were multi-system and we were in multiple states, but I had several representatives from revenue cycle there. And I had one in particular that we had measures that across the system, everybody was responsible for. We didn't necessarily do the measures. The measures were done by that department. We had somebody, but we validated and we checked it, and they got scores, and you had to meet a certain score. And if you didn't meet a certain score after so many sessions, then your CEO, ultimately, if you got, there was a penalty to it. And if your CEO was penalized more than once, there was a financial penalty associated with it. So the bonuses went away. And you know, when you play with the church's money, everybody got to have a conversation. And so much so that if it continued, that CEO had to have some explanation and explain to the board what was going on. And it was a whole process. And it was like, it was a serious, and there have been several CEOs that had to approach the board and have some crucial conversations. And I love that process was put in play because it kept everybody accountable at the end of the day. Compliance helps keep folks accountable if done right. Go ahead, Mr. Jesse. I know we always say, I don't know who are your compliance people that you running into, but
me either. They walk past me, I wouldn't know who they are.
So we had, like I said, so did you not meet compliance at your first orientation?
I don't remember.
Oh God. So we would make sure that somebody in compliance was there at the initial orientation. You had that all-day orientation or whatever when you first on board into the program. But then we would leave pamphlets, we would have little cards, we would have all kinds of stuff. We actually had monthly events where we're talking, and most of it was directed towards revenue cycle. So some of the activities, because it's still in me, some of the activities that I even do on my channel where we talk about, okay, IPPS is coming out, the final rule, the proposed rule, that was part of my work, what I did with those organizations, which I thought were a gem of, you know, hey, folks don't understand or know this. This is why we're calling you. This is why we're asking you to take a look at XYZ, because this is the information that we're getting from the government on what's important, or these are the changes that you now need to make note of. These are the changes that are occurring that may impact your department, ultimately the bottom line, and how you may treat your patients. So providing that information, we would do that on a monthly, it was like a monthly roundup where we would just come together and say, hey, this is what's going on. You need to know internally within the organization. I would have, and it would be, this was before COVID. So we would do this on a Zoom call, or it wasn't Zoom then, but we would do however, what was it, webinar? No, I can't think of the big one that all companies had, but however, we used to do WebEx. And so we would have a big thing and folks would come in and register and talk about and have questions and the whole thing. And, you know, we would do it for like 30 minutes. We tried to keep it because, you know, everybody's busy. So we do it like for 30 minutes and go. Yeah. So again, compliance professionals, you have to be visible. Folks have to know who to call. Also, we had a hotline number where if you had issues, if there was something that you had questions about and you weren't 100% sure, is this right? Is this, if it didn't, and I used to tell people all the time, if it didn't feel right, look right, smell right, it probably is not right. Please call me and let us know, because it's one thing for us to uncover it, investigate it, and slide the check. It's a whole different thing for outside to come uncover it and request not only that check, but the treble damages on top of it. So yeah. So you just, I don't know. And reach out and say, hey, compliance person, where are you? Come, you know, when you have and that would be another thing. We did have departments that will say, you know, we're having our departmental meeting. could you come and be on our agenda for this month? And, you know, just to get folks to know and see who was what and when, where, and why. And I know it's probably a little different now because everybody is virtual, but y'all still meet. And even if you meet virtual, they can pop in and say what they need to say and put a face with the name and position and move on. But yeah, you just have to have access and be able to talk to people and get to know the people and be allies with the people. Okay. Well, this has been our Saturday morning tea. Thank you all for joining and or checking out the replay. Let me ask, was the tea spilled today? Was it spilled? I think so. Okay. If this information was valuable, I'm looking for folks, but I'm folks going in and out. Everybody quiet today. Why is everybody quiet? I don't understand. Okay. Why are you muted? You got something going on in the background? I'm like, everybody quiet and everybody muted. All right. If this information was valuable for you, help us share this message with others by sharing this video and subscribing to the channel. Be sure to follow us for more information on all things health information, compliance, revenue cycle, and medical coding. And as you leave, don't forget to hit the thumbs up or like button. And also check out the Coding Nurse channel on YouTube. This has been a great session. Mr. Jesse, do you have any closing thoughts or final words? You're muted. We don't hear you on anything, sir. There you go.
I don't know why. I really enjoyed our conversation as always. I mean, this is what people have to understand when they come to the Saturday morning tea. Like, we get to nut and bolts, the meat and the potatoes of what is going on in HIN, because this is where it is. Like, you know, people want to have all that surface conversation and make it like it's, you know, all rainbows and unicorns. There's some real life implications to this.
That's right. That's right. And not only for your organization, but for you personally, if you don't do the right thing. But yeah. So more on that when we talk about compliance next week. Yeah. So again, thank you all for joining us. And remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care, and see you probably next week. Have a good one. Bye-bye.